All right, so now we're going to talk about hernias. And now remember, this time we're not talking about hiatal hernias. We're talking about hernias in the abdominal muscle and wall, where so that's different than the hiatal hernia that goes up through the diaphragm. Okay. Um, so hernias can be weaknesses in the abdominal wall where a segment of the bowel or part of the abdominal structure protrudes through. They can be reducible or irreducible. Um, and if you can reduce it, that means that it has less likelihood to cause strangulation. A strangulated hernia causes abdominal distension, nausea and vomiting, pain, fever, and tachycardia, and can be a medical emergency. But if it is able to be reduced, generally it will not strangulate. Um, Management, non surgical can be a truss. Surgical, it can either be laparoscopic, and involves placing mesh over the place where the hernia is to strengthen that area so that it doesn't protrude through again. And you can see on page 1139 in chart 56 7, um, where it discusses the surgical procedure used to put in hernia mesh for hernias. Here are pictures of trusses. You can see how it helps to hold in the hernia, how it goes around. And there's different ones for men and women, just depending on in the tightness, helps to hold the hernia in so that it doesn't protrude out. Common abdominal hernias can be in the umbilicus. They can be a congenital defect in the muscle. Sometimes it's just an outie belly button. Sometimes it's more something that needs to be fixed. It can be an incisional hernia through an inadequately healed surgical repair. It can be a femoral hernia through the femoral ring. It can be a direct inguinal hernia that's through an area of the muscle wall. It can be an indirect inguinal hernia through the inguinal ring. So those are the common places that you'll see abdominal hernias. Okay. Um, if patients have a hernia repaired, the postoperative care is fairly simple. A lot of times they will use ice if it is an inguinal hernia repair on a male. A lot of times they will use a soft pillow or actually usually just a folded pillowcase under the scrotum to prevent swelling. And they also will use ice on the wound. This is one of the few times that we're going to avoid coughing. We're going to use deep breathing and an incentive spirometry, but we're not going to have the patient cough. And we will encourage early out of bed and early ambulation. They will look for signs and symptoms of infection, redness, drainage from the incision, fever, just your normal signs of infection. There's nothing specific. Soreness is okay, but they should not have severe acute pain. And make sure that you look at chart 56 7 on page 1139. So now we're going to talk about hemorrhoids. Risk factors for hemorrhoids include childbirth, obesity, repeated straining, genetics, prolonged sitting or standing, vigorous exercise or weightlifting. Prevention can be hydration to avoid constipation, high fiber diets, maintaining a healthy weight, gradually increasing your exercise intensity and not going too intense right away. Symptoms can be bleeding, swelling, pain, and itching. Non surgical can be topical agents, hygienic wipes, cool packs, and a tepid sitz bath. A hemorrhoidectomy is a minimal surgery and is done, and it's a same day surgery. For these patients, I want to make sure that you look at the nursing safety priorities regarding postoperative care on page 1140. Keep in mind with that nursing safety, it's talking about their first bowel movement may hurt, and you want to make sure that the patients are aware of that and that they are not alone. Some people actually will vagal while having their first bowel movement. With that being said, these patients are usually given stool softeners, and they may be given a mild laxative if they have not had a bowel movement by postoperative day 3. Malabsorption syndrome. Malabsorption can be caused by a number of different disorders or surgeries. The ability to absorb nutrients is affected. Symptoms include chronic diarrhea being the cardinal symptom and is shared by most. Other symptoms can be bloating and flatulence, unintended weight loss, easy bruising. They can have anemia, whether it's iron, folic acid, or vitamin D. They can have edema due to their low protein intake, letting those little cell walls break down. Diagnostics can be serum labs. Low calcium can be indicative of malabsorption of vitamin D. Low cholesterol can be from the malabsorption of fat. Low protein, low albumin, total protein, serum iron. Look for fecal fat analysis as well. For patients with malabsorption syndrome, a lot of times they'll have a lot of fat in their feces. A lot of times these patients can be lactose intolerant. You want to do the Schilling's test looking for pernicious anemia, which is vitamin B12. And they'll do the bile acid breath test as well to look to see if they are having too much bile. Bile acid breath test assess for the absorption of bile salts. Okay. All right. So what are some of the treatments that are done for malabsorption syndrome? Depends on the cause. Sometimes it's just diet control. You want to make sure that you're replacing what is lost with supplements. A lot of times these patients require antidiarrheals, but remember the trick with antidiarrheals is making sure that they don't end up with constipation on the other end. Drug therapy to control the clinical manifestations. Nutrition, you're looking at a high protein diet, high caloric, and usually small frequent meals. Sometimes they'll have a gastrectomy if it is severe. Also, I want you to make sure that you look at the chart on 56.8, which is on page 1142, which is talking about skin care for patients who have severe diarrhea. It's always important to make sure that we're maintaining skin integrity for these patients as well. And that is it for chapter 56.